Title of today's session is Can Marketing Be a Public Health Intervention? And this is not a rhetorical question because we're going to test it together today. And by the end, I hope you'll feel equipped to answer it with rigor. We are testing this theory together, so we invite your participation. The plan today is for about a 20-minute presentation, and then we really want to hear from you, so the rest of the session will be dedicated to Q&A. And this will be recorded for circulation for those that had signed up today. So, welcome. So, the drum roll, why are we here today? The gap is huge and it comes as a tremendous cost emotionally and financially. Today, I know we have a mix of research teams, state, local, and health department personnel. But before we dive in, I'd love you to drop in the chat two things. What organization are you working with? And who are your target audiences? And while you're doing that, I might ask Christian to run a poll. Let's test if this poll works, Christian. I'll pass it over to you. I see the numbers coming in. I see a strong trend in favor of yes. And this matters because we're really exploring today is the translational gap, the space between evidence and access. So we'll give the poll just another minute and then we can come back with some good numbers. All right, we'll end the poll and we'll share the results for all to see. And I think that's a pretty good summary and a good starting spot. So thank you all for jumping in there. Let's move on. So DUP as a determinant. Well, the problem we're grounding this in is duration of untreated psychosis, something that everyone in this call is familiar with. And DUP is a key determinant of long-term outcomes. Earlier treatment correlates with improved quality of life, and longer untreated duration correlates with worse outcomes. And for many of these teams, reduction in DUP is not abstract, it's a KPI. So let's check in with another quick poll. These are always interesting to see where you're coming from. Christian, if you want to share the next one, pop it up and we'll go from there. Good to see there are many alternatives to DUP on the call. So this is great. All right, I'll end it there and share the results. And I believe you can all see. I'm trusting in that. So we'll circulate this as a recap, part of the recap. So it's important to really define what we all talking about here, public health as an intervention. And this is what we came up with in terms of criteria. That public health must target a population level problem. It has to impact the systems. It produces measurable outcomes. And at the end of it all, it alters behaviour. And these are the standards. So as we move forward, we'll continuously test marketing against these criteria. If it doesn't meet them, the answer is no. If it does, then we have to reconsider how we define intervention. So one of the biggest barriers here is stigma, and it comes in various shapes and colours. And I think we're all familiar with this framework: internal, the shame, the fear, the confusion, and the external stigmas around public misunderstanding, the media, Hollywood, provider hesitancy, and obviously funding gaps as well. And if you see any others or know of any others, we'd love to hear from you in the chat. So if stigma delays help seeking and delayed help seeking worsens outcomes, then reducing stigma becomes an intervention target, right? So last poll from Christian, and then we'll move on. But at the end of the day, what other KPIs drive your agency? Quick response, thank you. we're just looking for short answers here, folks, just keywords that will help us and guide our work going forward. So while we're looking at the poll rolling up, I just want to move on and talk about the pathways to care, or in some cases, we call this the client journey. And this is really where marketing enters. We sometimes, the slide looks at the pathways from awareness to care at the top. So each stage has emotional highs and lows. They also have decision points and drop-offs, or in a commercial environment, we would call that an empty cart. And there's often confusion, particularly with this group that we're dealing with. So it's really not moving in a straight line, but if we can identify friction points, we do design communication to reduce those. And the goal is simple, really, here is to shorten this journey. And hopefully, in your communities, you will convert people from not knowing about you to becoming fans of your brand and the work that you're doing at the bottom. So that's the goal. I think we should roll up this poll now. And I am not sure, because this is a short answer version, if the sharing is going to reveal much at this point. So we'll include this in the recap of the today's meeting and move on. So this is a concept that we developed in our commercial work, but it resonates more than ever now in this work that we're doing with this community. Another framework we use that helps us design the messaging is really what defines a future state. And these are emotional values that usually fill these buckets, and we're using it to describe how clients feel before in terms of what they have daily and how they feel after treatment. And it's a very useful way of structuring, of learning about their particular pain points. And it's an exercise in empathy and design thinking. And it really aligns people around a shared vision. It also reflects deeply emotional needs. So it's a culturally specific intervention design just through a communication lens. Before we worked in public health, we did a lot of work with larger commercial businesses. And one example, just to bring it down to earth here, was a company we worked for was a huge landscaping business. They all operated these shiny green tractors, these John Deere tractors, and they were very proud of their machines and being on time and loved their machines. And we weren't getting any traction in the messaging. So we asked the clients to go through this exercise. And at the end of the day, we found out that what all they really cared about was getting their day back. So that was a big status change in this, and it really helped us change completely the messaging that we wanted, that we were doing. And we ended up getting much more traction knowing that. So that's what the work we do with these communities is help understand the language and their pain points. And another chapter of our work when working with these communities is mapping out the assets in the community. And there's our hometown of Connecticut. But it really helps. I mean, you already have a pretty good idea of where your referral sources are, but this process identifies existing people, their relationships, their skills and organizations. And it also looks at the informal supports like peer leaders, caregivers, and faith groups that sometimes don't appear on an organizational chart. It helps the cultural knowledge and lived experience and develop trust in the networks. And with social, our work in social media, it also helps identify the physical locations and also their matching digital assets so we can begin to communicate with them online and so on. And a couple of examples, I think we were working with New Orleans group. They said some of these hairdressers have particular influence and in the community, and that's an example of what maybe wouldn't have appeared on any clinical version of this, but it's helpful for us to learn about the informal, unpublished parts of this network. And in Connecticut, I think we discovered a park that had similar influence. So very helpful to map out and know your community. So what are the shared levers? And obviously information dissemination, getting the word out. And it's hard these days. You've got a lot of clutter, a lot of competition. So the crafting and the dissemination of these messages is really important to get cut through in that. Engaging community members, and I think the clients that we've worked for have been tremendously effective in invigorating community engagement because they've got to want to help, and they do a lot of the heavy lifting in terms of communication, and all of that leads, of course, to behaviour change. I mean, these are not commercial tactics; they're intervention strategies. And they're all aimed at building trust because trust is the currency here. So, a couple of examples of how this works in the communities that we've been working with. Um, Trust plus visibility equals shorter pathways to care. It's pretty simple. And it's usually a blend of mass media and targeted digital. Trust reduces fear, it visibly increases exposure, and together they normalize help seeking. So these examples show how messaging appears across digital, outdoor, print, and community spaces. And this is not aesthetic. It's more like, what do we call it? Exposure dosage, putting it in your context. So obviously, lived experience plays a critical role in our messaging. It's a core mechanism in honouring lived experience. It humanises psychosis through personal stories, challenges stereotypes, and builds empathy. Research shows narratives reduce stigma much more effectively than data or any other abstract information. And when people see themselves reflected, the threshold for help seeking lowers. And in some cases, they've become raving fans. So we are huge proponents of that. And the other benefits, sometimes some of this is unintended, but the people with lived experience have become hugely involved. And I think Serena or Ashley might have some examples of how people with lived experience and through their art work has really been their biggest fans. So let's look at some outcomes, a bit of history here. And the first one that we worked with was Yale with MyMap 1.0, and it ran across the 10 municipalities in Connecticut, 10 towns. And it started in 2015 and finished in 2019. And it included a single referral line, a lot of digital and print advertising, a lot of targeted geo-fenced digital because it was 10 towns, easy to fence off, and a lot of professional outreach. The clinical team were very effective in that. And the DUP was reduced from 10 to 5 months over the 4 years. And that was dramatic, but it was also interesting to compare it to the control group in Boston. And they had a very comparable program running, zero marketing, zero messaging, and they had no change in their baseline. So this meets our criteria, right? Behavior change and outcomes shifted. Well, then there was COVID. So MindMap 1.0 was rolled out statewide not until 2023. And the key messages there on lived experience were also delivered by students with psychosis, a group that we have partnered with many times who do a tremendous work around advocating for this community. DUP was held steady from 10 to 5 months, but there were other engagement uh, measurements here on this slide in terms of how long people stayed in treatment. So that was interesting to see that they had rolled that data into the second version of the campaign. So it's not incremental change, it's structural impact. Another project we've been working on is CALM for the last 10 years in Louisiana. And the CALM campaign reduced DUP from 6.6 months to 2.1 months. And the key here was developing visual signals and verbal signals that resonate with local groups and values of New Orleans. We talked about the arts community as a good example of how their community organisation really mobilised. So it's not incremental change, it's structural impact that we're having here. Another example, a shorter campaign, much shorter campaign. This was just last year from June 2020, June to September last year, and really increased awareness, and it translated into early access. And the clinical team also became quite skilled at articulating the value of their work and doing a lot of TV presentations. So it was very empowering for them. And the client now leads the community internally. So that's been a good exercise in sustainability. So let's look at the system, at the whole bundle, if you like. The messaging and how if you add that up to reducing stigma and applying additional early treatment, then the outcomes, the better outcomes, become quite profound. It's like a multiplier effect, and it's really gets traction once you can demonstrate what that looks like and report back to the funders to see what the outcomes look like. It can be a very powerful tool. So how do you scale it? Because these elements become like a multiplier effect as well. The storytelling to humanize the issues and encourage empathy. We use a lot of design thinking in our work to really understand and empathize with our communities. The language you choose is critical. It's got to empower without marginalizing any other groups. Really, creating a clear call to action is essential in the work we do because in many cases they know what you're saying, but they're just not sure what to do next, particularly with this population. So clear calls to action are really critical. And then showing social proof and cultural relevance to scale interventions is a great way to underpin this work at scale. So it's not about volume alone, it's about maintaining fidelity while increasing reach. Just a couple of other examples of the work that we've done in this space, because this model, if we're calling it one, doesn't only apply to early psychosis, but other interventions as well. We've been working with the New York State and Columbia University in tobacco cessation and behavior for about the last 10 years on the left. And then in the middle, we just did a project with New Haven Health Department on lead poisoning prevention. And on the right side, and you'll see more of this in a minute, but the App Foundation in New Haven, we just did a really interesting campaign around opioid use disorder. And that work is, we've been doing that work for many years and it's continuing to gain traction. So we're applying these models to other environments as well. Let's talk a little bit about ethical considerations because accuracy really matters with this population, not only with HIPAA, but showing inclusive representation. And don't unintentionally stigmatize. We don't want to add to the problem, but being data informed without dehumanizing. We are Data is driving a lot of the work that we do as we've become more and more informed about the unique behavior of this community. So that guides us in our tone and texture with all our communications. Sorry, I forgot to set that up, but that was just a little sizzle reel that we put together to identify what the work looks like in our communities. So let's return to the question. If marketing reduces stigma, shortens DUP, increases intake, and improves system efficiency, then by our own criteria, yes, marketing can function as a public health intervention, but only when it's grounded in evidence, designed around behaviour, measured rigorously, and executed ethically. So let's introduce the Red Rock team. They're the ones that actually do the work. They're a highly creative bunch, equally driven by results and detailed reporting. Client reports align with business development goals, validating our impact. We have grown organically in team and headcount and the number of clients over the years because of these practices. We work virtually with autonomy at a regular cadence, accommodating our clients' different cultures and many cases, time zones. I'm very grateful to work with such a bright and motivated bunch of team members. Some of them are here today to help with Q&A. So a little over time, I appreciate your patience, but if communication changes behavior and behavior changes outcomes, then communication deserves a seat at the intervention table. So I look forward to your questions. And oh, by the way, I'll be presenting at the EPA conference in Prague at the end of March, and I would love to meet up with any of those that are in the audience that are going there as well. We're particularly looking to partner with organisations in research on stigma reduction. So let me know if there is any interest. So look forward to hearing from the group. If there's any questions, then let's hear from you.
Glenn, there are some that are submitted. Do you want me to just start reading you some off?
I'd love you to, Jess. Thank you.
Perfect. Okay, so the first one is, do any of the Red Rock team members work from the perspective of lived experience?
Not directly. I mean, we all have had challenges with mental health in various environments. So I'm not sure if that would count, but we are all advocates of the work that we do because we understand its importance on an impact on the community. So it's a blend of having the creative skills and the motivation that informs and inspires our work.
Great answer. Okay, next question. How did you honor lived experience in your development? They would like some examples and implementation suggestions if possible.
In the mind map, well, there's a long answer and a short one. Uh, with MindMap 1.0, we began collaborating with Cecilia McGow and the Students with Psychosis group when she was very early in her organizational development, and we've continued to partner with her to cultivate the voice of her members, to give her members screen time on YouTube and every other video distribution channel that we can think of, including TikTok, because we believe that their work is essential, that they are heard and understood by the clinical community, and that people empathize with them. And so they collectively work reducing the stigma positions that we talked about earlier.
Okay, another great question. If there is no funding for marketing, like you mentioned, what are some frugal options?
Well, this is good timing, this question, isn't it? Happens to be on everybody's mind. And I have to point to, I think, one of our guests, Serena, who's on the call today, because we started working with the Calm Group 10 years ago. And I think one of their initial financial structures was a GoFundMe campaign. So that's a great example of a frugal beginning. I don't know if Serena, if you want to jump in, yeah, I'd love to hear from you.
Yes, hi all. You're absolutely right, Glenn. Calm was started with a GoFundMe campaign that generated excitement, allowed us to partner with you, and we had a very slim budget in the beginning, and just worked with you all to create our logo and then capitalize on free or low cost opportunities in New Orleans to get the campaign out there. And as we generated recognition and excitement around the campaign, excuse me, we were able to get small grants here and there that eventually allowed us to host a annual fundraiser, and that fundraiser generated more money. So it's sort of money begetting money. They were small and simple efforts at the beginning, and we've been able to grow into a more sophisticated campaign as we've aged.
We've aged quite well, haven't we, Serena?
We have. And just to, I know concrete examples are helpful. We would go to restaurants with our campaign. We had little tattoos made of the calm sea. We would hand out paraphernalia. We had collected money at tables at restaurants after we talked to them about what we did. Very small, very low cost interventions that involved our team and our patients who were wanting and willing to participate.
And about 5 years ago, we decided to do a annual event, right? And that is now in its fifth year and its most recent iteration in November last year. There was a very successful fundraising component to that. So I'm thrilled to see you see the return on investment of the work that you're doing with the community because they become very engaged in supporting you both emotionally and financially. So it's a win-win.
Agreed.
All
Good.
right. For some reason, Jess, I can't see the question, so I'm relying on you to.
That's okay. I got you. Okay.
Yeah.
Next question. Do your campaigns typically always include a research component to measure effectiveness?
We're a creative bunch, but we geek out on these numbers and we want to not only do the work, but we need to see change impact, measurable impact. So the work we've done with MindMap and Calm have both qualified for that, and we are very excited about continuing that approach because we're not a marketing company as such. We're really motivated to do this work, and motivation is great, but if you can demonstrate impact at scale, then you're improving outcomes for so many people. And you're also proving to the funding community that the positive results are becoming part of the measurement of the work that we do. And that's been, I think, a bit of a turnaround moment for some of our clients is that our reporting has provided them very solid foundations for reporting to their funders to say, this is what we've done and these are the results that we've got. And in many cases, that's resulted in continued support. And so it should. If they can see results, then they're operating, you know, everybody's happy.
Awesome answer, Glenn. Okay, another question for you. What tips or suggestions would you share with a team who's just starting on a statewide social campaign?
Well, our social media, and Jess is our social media manager. I just want to introduce her that right up. So she might be good to answer this. But the accumulated wisdom that we have learned through 10 years of social media activity is substantial. And we are happy to share our insights to anyone on this call to initiate the beginnings of outreach. We know social media has been demonized by many, which is valid, I might say, but it also happens to be where a lot of this population are. So we go where they are. And Jess has had particular success recently with TikTok because that's seems to be where this population hang out. And the last campaign we did with the App Foundation, I think we got 600,000 views on TikTok because we were locked out of our usual hangout on YouTube because Google just introduced some new rules around working with their platform. So interesting that Google should become one of the barriers to treatment. But I think Jess came up with a good workaround on TikTok. Start small. We call them micro experiments. We do them all the time as a team and start with a measurable impact and something that you can scale up. We've met in the last couple of weeks with a few communities that are reaching the end of a funding campaign or financially not very fluid, and they have the same question, like how do we get impact? And it's start small. We often start with the discovery call with a client to figure out, well, where are you at? Because everyone starts in a different position. And some clinical teams have media people on hand, others don't. Some clinical teams are members of larger hospital groups, so they have some staff that can dedicate some of their time. So it's always different. We're willing to meet you where you want to start and go from there. So I'm sorry that was an abstract answer, but it's such a wide the needs are so diverse.
Great answer, Glenn. Okay, curious if there was any consideration of utilizing less medical language or steps taken to offer multiple explanatory models beyond the explanation of psychosis.
When we first started working with mind map, the big question was, gee, do we use the word psychosis? And we gave that a lot of debate, and we realized that it was a phrase that was best known in the community, so we were obliged to use it. So that was the opening, but the rest of the time we spent detuning the medical jargon of the research and clinical teams and translating it into everyday words that the consumer market is more familiar with. So we often work as translators in that without, diluting the scientific position or status. So it can be done when it's done thoughtfully. It can be done with great effect. And we've seen that with the work that we do because, you know, often the clinical teams, that's the only language they know. So it's not their fault, right? They need to just be reminded, and we use empathy as a tool here to say, well, your population has different needs, and in some cases, we have an obligation to change the language we use to make it more accessible. And with this population, you need to be simple terms often work best. And we've seen that to great effect across our work, and that's consistent with other commercial marketing strategies as well. Simplicity is key. So it's not something a strategy that we used with this community, but um, yes, I'm not sure if that was a good answer, Jess. You will correct me if it wasn't.
No, I think it was a good answer for sure. Okay, next up, we have, are there any tools you suggest to track analytics across platforms?
Well, the obvious one that's free is Google, and that provides a lot of behavior in terms of the website, and their AI backends have become more useful in interpreting what the behavior is and coming up with some simple solutions to improve the user experience. We look at the pages that we've built with our clients and try to get them as sticky as possible. We have created pages like quizzes that are very useful and educational. So some of the stickiest pages on the websites we've done are around about the quiz. And the quiz also produces interesting data that the clinical team can use as well. So it's something that has become very useful for both parties. In terms of social, the analytic tools, you might speak to that, Jess, if you care to, just in terms of how we use our social as a listening device.
Sure.
And our Kim is not on the call. She's buried in 3 feet of snow, but I'm sure you can articulate a good story in that light.
Yeah, absolutely. So, in terms of analytics for social, number one, obviously, everybody has access to their own platforms, right? So, you can use the in-app analytics for things like Instagram, TikTok, etc. Another thing that we utilize is we do have a scheduling platform. And within our scheduling platform, you can see historical data for about as long as you have had your accounts connected. And so, the good part about that is there is a reporting component of utilizing those platforms. And more often than not, you're able to go back a lot further than you would be able to do in, like, for example, Meta platforms. Because Meta implemented a 90-day rule. So going back 3 months is about the max that you can do in platforms. So utilizing something like a scheduling platform, for example, we use Sked. You can use the reporting in there and go back, to the last year and actually check your analytics that way as well. So that's a good place to be able to take a look at some more analytics that you may not be able to see on the day to day just in platforms. And then in terms of listening, we're able to, be on top of connecting with our mutual connections, being able to collaborate across different accounts. And so we're really able to build analytics in a way that shows qualitative data instead of just quantitative. We're able to show both because you can see the actual impact that you are making with real human people every day.
And if I can just finish with another piece to that, is that Kim has been quite successful in identifying other peers, a lot often with lived experience, that have their own social groups and followers, and we've often collabed with them or had them as podcast guests or some other way of meeting them in a collaborative space and using their or leveraging their population, their community, their followers has been a really important way of getting the brand out there.
Great answer. Okay, another one, Glenn. Do you have experience in public information campaigns around the connection between cannabis and psychosis?
Not yet. We'd love to. I mean, it's becoming more and more co-joined as themes. We work with obviously cannabis users within all of our communities, but we're yet to do something that's intentionally freestanding. But the more the stronger those drugs become, the more apparent it is that it's a requirement. It's something that needs to be looked at. So I would welcome any work that we can become involved with in bringing those two themes together because I think they're responsible for some very interesting outcomes.
Yes, and Glenn, as preparation for that, Eleanor Slamba, Communication Director here for Red Rock, I would say that the cannabis use was included in a high risk group campaign that we did for Calm, where we did billboards and things about different factors that people might need to know about that place them in a higher risk category, family history being, of course, another one.
Thank you, Eleanor. Yeah, CHR community are, are becoming more prevalent in their particular needs, and that is a good example of those. Thanks, Eleanor. Jess, was there anything else? I'm sorry, I can't see.
Yes, there are a few more. Okay.
Mm.
I was wondering if you have found any particular pitch angle captures attention the most in terms of recovery outcomes. When talking to reluctant clients, it's often most helpful to talk about dating, reconnecting, or building new friendships slash family connections, work, school, and just understanding what's going on and how to live with it. The ads for things like BetterHelp don't seem targeted enough, but otherwise it would feel to me like an ad for a technical school. What have been your learnings there?
Better Help Technical School. That's a great join up. Our clients in our populations, and Serena might want to jump in here too, they just want to live a normal life. So, how do you pitch a normal life is, it can be a fairly vanilla flavored proposition. But in their case, it's a superpower of some sort. So,
Okay, another question. With all this collaboration, how do you minimize the burden on staff who are already stretched thin time-wise?
well, of course we are, right? I mean, Ashley or Serena had to drop off for a clinical appointment. And we roll in as an agency to understand where their pain points are in communication and collaborate with them to create it. We meet weekly. We are very collaborative as a team. We understand that they have fairly strenuous clinical environments that they've got to work in, so their availability is often, restricted. So that's really been, I guess, one of the benefits of working with so many communities is that we understand that as an agency. Sure, we're here to help, and helping doesn't require a huge time investment at their end because we're already familiar and confident and empathetic with this community. So I guess we have been able to reduce that contact time, knowing that we can come up with the right content with the right tone that suits their community.
Absolutely. And I would say too that if there is an existing meeting structure that's already kind of on the books, like say we're doing a quick asset mapping round with program directors or something, we'll look. And if they have standing meetings, become part of that agenda so that nobody has to add something new to their calendar um, in order for us to gather the assets that we need.
Okay, Glenn, another question. What have you been most surprised by in this work?
Well, the impact that we can have. I mean, it's working together with clinical teams, which is an exciting, intellectually an exciting environment for me and the rest of the team because we're we're learning just by osmosis how these communities function and what their needs are, and being able to do something about that is tremendously exciting for us as a team, and that's what motivates us, and that's why we're here today is to talk about it and to offer other communities that are struggling a little bit with the language or the traction or the community building and come in and help move the needle. So it's not been a surprise, I guess, but it's been very fulfilling.
Good answer. Okay, I think we are down to our last question. Unless anybody else has any, feel free to toss those in the chat or in the Q&A box. What does a contract with your agency look like, and how does an organization get started?
Well, we can start small. I mean, that's because we understand the current financial environment is pretty grim. But that also presents an opportunity and timing to get things moving when there's very little other activity to work with. So we would set up a discovery call where we'd look at some of those tools that we mentioned in the webinar and find out what your goals are, what your team's status is at the moment, your starting point. And like I said, they're all different. And the needs, particular needs of the community. I mean, we've been working in Connecticut population, and we're working with the population in New Orleans. And so demographically, those two are quite far apart, you might say. We, as a group, are really interested in the differences and the social texture of your community. We're sort of interested in the psychology of the work we do, and knowing that the tools we use are always different. TikTok wasn't around a few years ago, and now it's one of the most influential places to be. Social media is sometimes a risky place to be. You can see bad performers like X and the impact they can have. So we really favor building a website that you can call your own. You own it. You're not renting it. You build on that. So often the work we do with social is feeding into building email subscriber lists. So you can generate a small list of really motivated fans of the work that you do. And so all different starting points and in many cases different KPIs, but we're very open to working with different groups in different communities.
Great answer, Glenn. That about covers all of our questions.
Am I done? Wow.
I believe so.
Well, I'm sorry I couldn't get to see you all. I don't usually operate well in this webinar format, and I think we're going to go back to meetings because I like seeing people in the audience and getting some feedback. But I trust it was useful. The last hour, we'll be sending out recordings and some reports as follow-up to this call. And I'd love to hear from you just to talk about where you're at, where you want to be. And we've got a lot of experience with this community and we are very excited to share it. So that might be a good place to leave it. Thank you all. Bye bye.